Yeah, so this is Dr. Aftab, and I'm from Apollo Hospitals, Kolkata. And basically, I'm going to be speaking on the role of antiplatelets in the current evidence with the use of DAPT or SAPT in complex PCIs. So I think we are all aware that in ACS, this is something that is already known. We already know that the thrombosis is an important part, and platelet activation and aggregation plays an important issue. And therefore, antiplatelets really have a great role. It's always been dual antiplatelets. So it's been always aspirin with a P2Y12 inhibitor. And this is something that's been recommended universally in ACS. The guidelines right from 2014 to 2016 have mentioned that we need to use a DAPT. And when you look at stable coronary artery disease, so if you're putting a stent in a patient who's had a stable coronary artery disease, one needs to continue a DAPT for a minimum period of 6 months at least. And one could go higher or lower. So one could stop it at 3 months if there's a bleeding risk, or one could continue for more than 6 months if one feels that he's done a complex procedure, say a type C lesion. And therefore, for those patients where you have a complex anatomy, or if you have a prior MI, even in a stable coronary artery disease, one could continue DAPT for a longer period of time, though the guidelines would say that 6 months should be enough. And of the drugs that we use, aspirin is one of the primary cornerstone. And we know that the doses from aspirin is dose dependent, or the bleeding of aspirin is dose dependent. And this is the data from the CURE trial. Less than 100 milligrams is one that causes the least amount of bleed. And a higher dose is what causes a great amount of bleed. And therefore, the guidelines usually talk about a range of aspirin between 75 to 100 milligrams, and a range of usually 81 milligrams is what is normally recommended. Now, we don't really have 81 milligrams in India, and 75 milligrams is something that should normally be used to prevent a bleeding risk in patients who are on DAPT. Besides aspirin, it's the P2Y12 inhibitors, and I think we are all aware, and Dr. Sarat also presented his data about cangrelor, but I'll talk about the oral P2Y12, and we have these three major drugs, and clopidogrel has been there for long. We know that there's a little problem with this drug in India. We know that there are certain patients who are clopidogrel resistant, and this is an issue which happens where you have put in stents, and the patient, despite being on DAPT, would come back with events. And therefore, these two new kids on the block, well, new in the sense that they've been around for at least more than 4 to 5 years, but these are drugs that have now replaced the old clopidogrel in more and more patients. And there are specific reasons why we move on to ticagrelor. Well, it's a drug, and it's not a pro-drug. It does not take time. It has a rapid onset of action, and there's a more greater and a more consistent inhibition of antiplatelet activity as compared to clopidogrel. And this was the data based on the Plateau trial, 16% relative risk reduction in the major adverse cardiac events. And this is what changed the data. And as a result of this trial, the 2014 guidelines, which had initially said that you could use in a patient with ACS, if you did an intervention, you could use either clopidogrel or ticagrelor up to a period of 1 year, unlike stable coronary artery disease where you need to continue for 6 months. If you did an intervention on a patient with an ACS, the guidelines usually mention continuing for a period of a year.
वो आपका नंबर जैसे ही उन्होंने हाल
background disturbance there.
तो फिर बोला आप लोग ठीक हैं लखनऊ में, हमने कहा ठीक है. तो फिर उन्होंने पूछा कि मम्मी भी वहीं, हमने कहा नहीं, वो कानपुर में है. तो बोले अच्छा ठीक है, बाकी वो ठीक है. हमने कहा तो बोला ठीक है, उनका नंबर हमको दे दीजिएगा, फिर हम ऐसे हाल चाल पूछ लें. बस इतनी बात. ना उन्होंने पूछा कि आप इस समय कहाँ हैं.
It is difficult to continue like this with the background noise. Hello. Yeah, so with the clopidogrel and the ticagrelor, the initial guidelines said that you could use either of them. But after this trial, the 2016 guidelines now went more in favor of ticagrelor rather than clopidogrel in preference as a primary drug of choice, along with either prasugrel in patients when you wanted to put it in patients with ACS. So ticagrelor got a higher grade as compared to clopidogrel in these patients. And the duration of therapy was restricted to a period of 12 months as a norm. One could go higher or lower. So one could stop at 6 months if there was a higher bleeding risk, or one could continue longer up to a period of 3 years also if one felt that there was a higher risk of thrombosis. So the guidelines, therefore, as I said, for these patients for stable coronary artery disease, the DAPT guidelines were for 6 months. And for patients with ACS, the guidelines were for a period of 12 months. Well, one could go higher or lower based on their bleeding risk, or patients where there is a high thrombotic risk. So this is a problem that we often face in our clinical practice, balancing out the risk of stroke or thrombosis with the risk of bleed. And there have been guidelines which have talked about the various the risk factors. But unfortunately, the patients who have had a high risk of bleeds are the same patients who have a high risk of thrombosis. So advanced stage is a high risk of bleed, but it also happens to be a high risk of thrombosis, as is diabetes and as CKD. So it does become a difficult balancing act. And we know from our data that when you're doing a non-complex PCI, a short DAPT versus a long DAPT, there may not be a difference in clinical outcomes. But for a complex PCI, a short DAPT may end up causing more event rates as compared to a longer period of DAPT. And therefore, certain scores were validated, the DAPT score or the precise DAP score. And these scores were basically meant to help us to make a clinical decision as to decide when to give a long DAPT or a short period of DAPT. So when we did a complex PCI, a long DAPT was much better, as in this shown in this paper. When you did a non-complex PCI and a short DAPT, did not make a difference in terms of event rates, whether it was ischemia or it was MACE. And this balancing act, as I said, was basically based on the duration of DAPT, whether to give a shorter duration. But now what we have moved on to suggest to understand whether rather than giving DAPT, should we move on to a monotherapy. Now, amongst the drugs that we use, as I said, aspirin and P2Y12, which of this should we knock off? Should we continue with aspirin alone and get rid of the P2Y12? And there were two studies, the Onyx 1 study and the Evolve Short DAPT study, where it looked at the monotherapy after the period of DAPT for 1 month and 3 months, where aspirin was continued. And these studies also showed a benefit of aspirin therapy alone. But then again, the other group was to get rid of aspirin and continue with the P2Y12 inhibitor. The initial trials, which had the stop DAPT trial, where clopidogrel was continued after stopping aspirin after a DAPT of 1 month, and aspirin monotherapy was continued. And this also showed that you had lesser amounts of bleed without an increase in your thrombotic rates. And similarly, the stop DAPT trial, the smart choice trial, also looked at clopidogrel monotherapy. But then here 77% was clopidogrel, but you also had the other P2Y12, especially ticagrelor. Amongst the data that we have now as monotherapy, and this is the molecule which has really worked well, ticagrelor now has the greatest amount of data that we looked at as terms of as use of a P2Y12 drug as a monotherapy. So the global leaders trial was one of the largest trials initially, which had almost 16,000 patients, where monotherapy was DAPT was given for a period of 1 month, and thereafter it was only ticagrelor was continued in a dose of 90 BD for almost a period of 2 years, vis-a-vis a comparative study where the patients in the other arm had a DAPT for a period of 12 years, for a period of 2 years. This trial surprisingly did not show any difference in either the death or adverse outcomes, either in terms of thrombotic events or in terms of bleeding risks. So initially it was thought to be a negative trial, and therefore ticagrelor was thought that this therapy may not be good enough. But a post-hoc analysis was done, and Patrick Sarais, who's the lead investigator of this trial, has demonstrated that the patients who had the most complex anatomy, in fact, were the patients who got the best benefit. There was a 36% relative risk reduction in terms of death and non-fatal MIs when monotherapy with ticagrelor was used, unlike a DAPT with aspirin and ticagrelor. So now, since then, there's been a host of data that has appeared with the use of ticagrelor as a monotherapy, and we now had Themis and the Twilight. Well, this was one of the trials that really came in forth, and this was a trial where aspirin was used along with ticagrelor. India also had a large number of patients who contributed to this trial. So what was done in this trial? Mehran was one of the Roxana was the PI in this trial. So what you did was a DAPT with ticagrelor and aspirin for an initial period of 3 months, after which you dropped the aspirin in one of the arms, which was ticagrelor and placebo, or you continued both these therapies together for a period of 12 months, and then there was a follow-up period of observation. And this was a trial, again, which included a high-risk subset of patients. So it included diabetic patients, included patients who had long stents, patients who had bifurcations, patients with left main disease. And what they looked at is thrombosis, the thrombotic events, as well as the bleeding endpoints. And this trial, again, like the earlier global leaders trial, which was a negative trial, but this trial showed that there was a significant reduction in terms of bleeding risks without there being, so the bleeding risks really came down. The BARC 2, 3, and 5 bleeding risks were much lesser in the monotherapy arm without there being an increase in the thrombotic risks. So ticagrelor alone did not result in more thrombosis as compared to a DAPT. So the conclusion of the twilight was that when you give ticagrelor with aspirin alone for a period of 3 months and then followed up with ticagrelor monotherapy, this was superior in terms of bleeding. So there was less bleeding and without an increase in the ischemic endpoints over a period of a year. So I'll just quickly finish two large meta-analyses that were looked at. This first one was in the American Journal of Cardiology, where they looked at 4 major trials. And as I said earlier, the ticagrelor is the one which has had the major data. The Twilight and the global leaders contributed almost 20 to 25,000 patients who were studied. And with the other 2 drugs, with clopidogrel, we have a smaller group of patients with the stop DAPT and the smart choice. But again, this trials, the meta-analysis also showed that when you had a P2Y12 monotherapy, there was an increase or a benefit in terms of major bleeds. So you had a odds ratio which favored the P2Y12 when it came to bleeding risks without there being an increase in the thrombotic risks. So this was the group or the monotherapy which really scored. And this benefit was seen in almost all the group of patients: diabetes, CKD, younger patients, older patients, women, men. And this is the other meta-analysis which was there. Again, the Don Hort analysis, which was in the Circulation. And again, he looked at 5 different trials along with the global leaders. They also looked at TICO. And again, as I said, which again looked at P2Y12 inhibitors, of which ticagrelor had the major contribution. And this meta-analysis of the 5 trials also has shown that when you discontinued aspirin within a period of 1 to 3 months after PCI, and then you continued it with a P2Y12 inhibitor alone, as compared to a DAPT, you had a lesser amount of bleed. So your bleeding events outcomes were much better with the monotherapy without there being an increase in the MACE rates. So your thrombotic rates really did not worsen. More studies are in the pipeline to look at the monotherapy studies, and we have these studies in the pipeline, and hopefully we'll have more data coming up. But as to conclude, I would say that when we are looking at monotherapy now, it will be ticagrelor as a primary choice when it comes to P2Y12 inhibitors. We also have data with clopidogrel, but the host of data is more in favor of ticagrelor. And this is something that we would look at very closely, especially when you have a patient who has an HBR or a high bleeding risk. So we have data to almost a period of 3 years when it comes to Pegasus TIMI-4054. But again, one does not know beyond that whether one should continue monotherapy beyond that. So I'll stop here. And
Aftab, yeah, I'm Dr. Tiwari. I'm one of the chairperson.
Yes.
Yeah, that's a very nice elaboration of the very important subject. And my question is, a person who underwent a PCI and on a dual antiplatelet therapy and has to go some elective major surgery. So what the guidelines says, if the patient on aspirin and ticagrelor, as you said, so what should be the protocol?
Right. So I think when we look at the data, so we don't have much of a data right now. So we would probably look at the Onyx study now. The Onyx study has really shown us that when you could probably continue with aspirin monotherapy also after a period of a month of DAPT and get rid of the clopidogrel. So when if you're using an Onyx stent, then that would probably be my choice to get rid of the clopidogrel and continue with the aspirin or get rid of the P2Y12. But when we don't have when you're not using clopidogrel and you have probably a ticagrelor, then probably it could be just be the reverse. You could probably get off the aspirin and continue with the ticagrelor as your choice of P2Y12. But if you look at guidelines, well, we don't have exact guidelines which tell us what we should do, and you probably would have to rely on the clinical status of the patient to decide the high bleeding risk versus the high thrombotic risk. So the advantage with P2Y12 continuation and aspirin discontinuation is that it has been shown to reduce the bleeding risk without increasing the thrombotic risks. So given a choice, yes, that would probably be a much better choice to do rather than continue with aspirin monotherapy.